We're going to talk about non-steroid anti-inflammatory drugs, Nsaids. Nsaids are anti-inflammatory drugs that blockade the arachidonic acid cascade via cyclooxygenase blockade. Cyclooxygenase is the enzyme responsible for cleavage the arachidonic acid into prostaglandin 8-2. Depending on which enzyme acts over PGH2, it will form four types of products: thromboxane A2, prostacyclins, prostaglandin A2, and or inflammatory prostaglandin. The inhibition of COX will promote the decreasing of prostaglandin, prostacyclin, and thromboxane synthesis. There are two isoforms of cyclooxygenases, COX-1 and COX-2. COX-1 is expressed constitutively in most tissues. It has a protective role in platelet aggregation, gastric cytoprotection, and renal blood flow autoregulation. COX-2 is induced in an inflammatory scenario, and it is mainly involved in production of inflammatory mediators. It is described that the anti-inflammatory effects are related to COX-2 inhibition, and on the other hand, the unwanted effects are related to COX-1 inhibition. Regarding the therapeutic approach available, there are drugs that are selective inhibitors of COX-1, such as aspirin in low doses. There are drugs that are selective inhibitors of COX-2, such as the coxibs, the celecoxib, and eterocoxib. And there are the non-selective inhibitors, such as ibuprofen, naproxen, and aspirin in higher doses. Basically, Nsaids play three roles as therapeutic agents. It has an anti-inflammatory effect, decreasing the prostacyclin and prostaglandin A2 production. It has an analgesic effect, promoting less nociceptive sensitization. And lastly, it has an antipyretic effect, inhibiting the release of prostaglandins on central nervous system. The mechanism of action of Nsaids involves the inhibition of arachidonic acid oxidation, and it begins with the binding to hydrophobic channel, and with that the substrate cannot access the active site of the enzyme. The selectivity of COX-2 inhibitors comes from its bigger size than when compared to COX-1 inhibitors. COX-1 and COX-2 inhibitors are reversible binding to the enzyme, and just aspirin binds to active site of COX in irreversible manner.
Here are just some side effects. Decreasing PGA2 and PGI2 levels contribute to damage in gastrointestinal system. This is prostaglandin decrease acid secretion and therefore protect the mucosa, especially in the stomach. So, for example, patients might develop ulcer and gastrointestinal bleeding. Also, PGA2 and PGI2 play an important role maintaining renal blood flow. So when these molecules are inhibited, some kidney destruction might appear. In addition, COX inhibitor might cause hypertension, mostly because of the opposite effect that these drugs have comparing to antihypertensive therapy. Cardiovascular events are more associated with COX-2 inhibitor, and some drugs like Vioxx increase the risk of heart attack and stroke. Finally, the use of COX inhibitor causes dispersion in the cascade from COX to LOX pathway, increase the production of leukotrienes, a potent bronchoconstrictor. Around 5% of patients who use non-steroidal anti-inflammatory drugs experience aspirin-sensitive asthma. In regard to drug interaction, we just focus on aspirin because the drug gathered the main interactions found on non-steroidal anti-inflammatory drugs. So the first interaction that we're gonna talk is aspirin and anticoagulant, especially warfarin. Aspirin displays warfarin from plasma protein and also have effects on platelets that compromise homeostatic mechanisms. The second interaction is between aspirin and ibuprofen. The administration of ibuprofen and aspirin antagonize the irreversible platelet inhibition induced by aspirin. In addition, the treatment with ibuprofen in patients with increased cardiovascular risk might limit the cardioprotective effect of aspirin. Finally, the use of ibuprofen with aspirin might decrease the total anti-inflammatory effect. Aspirin interferes with the effects of some antihypertensive and uricosuric agents because aspirin reduces urate secretion. Finally, in the last part of the presentation, just gonna present some case study and the potential answer for that. So, Mr. James Abbott, 76 years old man, went to the hospital complaining about angina, raising of blood pressure, stomach pain, short of breath, and decreased urine output. He's very concerned because no cardiovascular issue appeared since a completely lifestyle change 10 years ago. During the appointment, Mr. Abbott admitted the use of aspirin after a friend's recommendation when he cut himself during a trek in Tasmania last year. Ever since, he's taking aspirin daily in order to avoid any future inflammatory reaction. He said, aspirin and Metallica Black Album are the best things that humanity have created. Based on that, what do you recommend to Mr. Abbott if you were a doctor? Well, the doctor might say to interrupt the use of aspirin because the chronic use of the drug can cause all the symptoms that patient is facing. In addition, the doctor needs to educate your patient, say that self-medication is a real problem, especially in old people.